Boa noite a todos e sejam bem-vindos ao nosso segundo dia de evento. Hoje contaremos com os blocos O Futuro da Relação Médico-Paciente, com o Dr. Abraham Verghese de Stanford, Interfaces entre Tecnologia e Reabilitação, com a professora doutora Linamara Batistella, o mestre José Augusto Fernandes Lopes e a professora Marta Imamura, e por fim o bloco Acadêmicos, com Larissa Alexandre, Cauê Gasparotto e Felipe Machado. Antes de iniciar o nosso primeiro bloco, O Futuro da Relação Médico-Paciente, eu gostaria de passar um breve recado. Esse bloco será conduzido em inglês para a comodidade do Dr. Abraham Verghese, mas vocês podem ficar à vontade para enviarem perguntas em português e nós iremos nos encarregar de fazer a tradução para o Dr. Verghese. Toda a aula inaugural será disponibilizada no canal de YouTube da MedTech e esse trecho será legendado. Eu passo agora a palavra para o nosso orientador, Dr. Leandro Insman, e desejo a todos um ótimo evento.
Boa noite a todos. Eu vou passar agora a falar em inglês, tá bom, pessoal? So, good evening, everyone. It is my pleasure and honor to be here with you with such an honorable guest. I first saw Professor Verghese back in 2012 when I saw his TED Talk, A Doctor's Touch. This TED Talk has now more than 2 million views on YouTube and TED website. I was amazed on his approach to the doctor-patient relationship and his approach to how technology should bring us closer to the patient and not further away. From then on, in every meeting I had every year with the group of residents that I'm a mentor of in the Institute of Orthopedics, once a year we had a discussion about the doctor-patient relationship based on his video. So I've seen it quite a few times, but every time I watch it, I get the goosebumps because I find it amazing. In 2018, I went to Stanford to study for a year. And before going there, I had a list of goals, of things that I wanted to do in Stanford. And at the top of my list was to meet Professor Verghese in person. And I was very happy to accomplish this goal. Professor Verghese was kind enough to receive me, and we could talk for a while about his TED Talk, about what he did. I got the opportunity to watch at one of his classes with students, so that was a great honor. And now I'm very honored and proud to bring Professor Verghese to Brazil virtually and to bring him to the University of São Paulo and especially to MedTech. But now, without further ado, I'd like to introduce Professor Abraham Verghese from Stanford. Thank you very much, Professor.
Thank you so much for having me, Leandro. It's a pleasure to see you. I remember your visit very fondly. Special thanks to all your medical students who are working so hard to make this conference happen. I'm really excited. So I think before I start, I just want to say that in America, we have lost approximately 1,200 healthcare workers because of COVID. And I'm sure that the situation in Brazil and elsewhere in the world is very similar. We're living in a very dangerous time. And I think I want to begin by acknowledging the realities of our world and just how much stress we're all going through. So this is a delight to be able to visit with you and to think about the doctor-patient relationship in these times. I'm going to share my screen for a second. And tell me if you're able to see my slide. Yeah, you see my slide?
Yeah, and it's presented.
Okay, perfect. Good. So I thought I would begin, first of all, by showing you a paper that was written by a colleague of mine. And I want to tell you that this is not the kind of paper that I usually read. The paper was in Cell, and it has a very scary title. Personal Omics Profiling Reveals Dynamic Molecular and Medical Phenotypes. But just to give you a sense of what this paper was about, this paper was all about the senior author, Michael Snyder. What they did was they studied Michael very intensely, as I'm about to show you. So if you look at panel A, I don't know if you can see my arrow, but you can see on panel A that they studied Michael for almost 400 days. And during that time, Michael developed two infections, two ordinary respiratory infections. One was an HRV infection and one was an RSV infection. The second infection, the RSV infection, triggered diabetes, and he became a diabetic. essentially there was something in his genome that made him predisposed, and that gene was turned on. Every so often, very often, they were getting blood tests, but they were getting much more complicated tests than the usual blood count and differential and sodium. They were getting the whole genome, the whole transcriptome, the whole proteome, the metabolome, the microbiome, and then they were doing these very sophisticated analyses. That's called integrated personal omics. And finally, at the bottom here, you can see this circle, and this circular plot is called a circus plot, in which they, going from outside in, they have the chromosome number, deletions, duplications. Why am I showing you this slide? I'm showing you this slide because the entire data for one person for 400 days was more than all the material in the Library of Congress. Just to remind you, the Library of Congress in Washington, D.C. has 838 miles of bookshelves, 153 million items, 35 million books, and one individual's data was more than all that. So that's what's coming down the pike. That's what's coming in medicine. But I want to stop now and ask, how did we get here? How did medical diagnosis arrive at this level of data, of complexity? And I often like to ask my medical students, I'd like to ask you, when do you think modern diagnosis began? If you had to put a date for modern diagnosis, when do you think that is? And I think most students will say Hippocrates or Galen or Paracelsus, but I actually think that modern diagnosis began much more recently. And I would credit this individual, Joseph Leopold Auenbrugger, who was a physician in Vienna. I would credit him with being the dawn of modern diagnosis. So Auenbrugger was a physician in Vienna, but as a little boy, his father was a hotel keeper, and he remembers that his father would go down into the basement of the hotel, and he would tap on the sides of the barrels of wine to try and determine how much wine was left and whether to reorder to get more wine. And so when Leopold Auenbrugger became a physician, he began to tap on his patients. And everything we know about the art that we call percussion, he described in this book called Inventum Novum. And if you think about it, it was really the ultrasound of its day. It was the first moment that people could look inside the body in life and be able to tell that there was a pleural effusion, there was enlargement of the heart, enlargement of the liver, collapse of the lung, and so on. So it was a really major advance in diagnosis. It was followed very soon by the invention of the stethoscope. People used to listen directly against the chest wall with their ear, but then Laennec developed the stethoscope, which he first called Le Cylindre, and then over time it changed its name to the stethoscope. And all of a sudden, around the early 1800s, you had an explosion of diagnostic technology: the blood pressure cuff, the thermometer, the reflex hammer, the ophthalmoscope. All of these were rapidly invented, allowing us in life to more carefully study the patient and the inside of the body. You have to remember that prior to this time, no matter what was wrong with you in most Western countries, you would go to see the barber surgeon. The barber surgeon was someone who would cut your hair or pull your tooth. But if you were sick, you could also go to them and they would bleed you. They would cup you or give you a purgative, or they would cut your veins and bleed you. You do not know, the red and white barber pole that you see there represents the bloody bandages from the barber surgeon bleeding the veins. And these receptacles represent where the blood was collected. So 1819 was a very remarkable moment in time when all of a sudden the physician who carried the stethoscope in their pocket was signaling that they were no longer a barber surgeon, that they were trying to make a diagnosis in life, unlike the barber surgeon who, no matter what you went to him for, would cup you, bleed you, or purge you. That's all they could do. I like to show medical students this painting because it really is the most famous medical painting in the West. This painting is called The Doctor by Luke Fields. And for reasons that are not clear, it was really a painting that compelled the public. It captured the public's imagination. It was hugely popular. And it's interesting to think about why. I think partly because it was a time when painters were moving to take on things of social importance, not just Greek gods or religious figures, but they were taking on the problems of the world. And Luke Fields was challenged by Tate of the Tate Gallery, who was a very wealthy man. He was challenged by Tate to paint a painting of social importance. And Fields decided that he would try and put on record the status of the doctor in our time. And as you can see, the painting is dominated by this image of the sick child in the center of the painting. The child looks very ill. There's something about the position of the hand that suggests that the child is really quite sick. The child probably sleeps in the back of this cottage on the floor, but because the child is ill, it's been brought to these two dining room chairs. And then you have the family on one side, the mother praying, the father looking on, and then you have the figure of the doctor. And interestingly, even though this is the era of the blood pressure cuff, the stethoscope, the ophthalmoscope, the painter decided to leave all those things out. I think because he didn't want us to be distracted by the doctor's singular attentiveness to the patient. You know, there have been many papers written as to why did this painting become so popular? How come it's on postage stamps from 17 different countries? What is it about this that made people so drawn to it? And I think that despite the title, The Doctor, I think that this painting is really about you and me projecting ourselves into the position of this child. If we were sick like this child, then this is the kind of attention and attentiveness that we want from our physician. And I think that that's why this painting has so much appeal. I think it echoes the lines that you will find in almost any religious text. But in the Bible, in Matthew, there are lines that say, I was hungry and you fed me, I was naked and you clothed me, I was ill and you cared for me. So I think that this painting really embodies the caring function, the Samaritan function of being a physician. And I've often wondered, what would Fields, the painter, what would he have painted if he was asked to paint the doctor in our time now? What would that look like? And my great worry is that it would look like this, because we have so much data around the patient now that the data almost is more than the patient, and we spend a lot of time on the computer looking at the data as opposed to looking at the patient. Now, this is a picture of medical rounds in two different eras. On the top left, you can see a very famous infectious disease physician. That's my specialty. I'm an infectious disease physician. And I trained at this hospital, but a couple of years later. This is Maxwell Finland, a very famous physician. And these are famous people in infectious disease who are in their training phase right now. But as you can see, the entire data on the patient is probably in the head of the intern. Sorry. There is no computer. There is not a lot of data that is not on the clipboard or not in the head of the intern. And contrast that with now the way rounds can be, where a lot of the time is spent digesting the data, almost to the exclusion of seeing the patient. And the question I want to ask is, can we really abandon the patient and focus only on the data? Is there a danger if we do that? And I think the answer is yes. I think if we rely too heavily on technology and don't really wed it with seeing the patient, there are four consequences. One is patient dissatisfaction. That should be fairly obvious. Physician wellness. The third is medical error. And the fourth is loss of ritual. And I want to speak just briefly about each of those. Patient dissatisfaction should be fairly obvious. I think most of us have heard our family members complain that when they go to see the doctor is looking at the screen and not looking at them. especially true in America. Maybe it's a little less true where you are, I hope. But I picked an example from a patient who was before the computer era. This is a very famous writer by the name of Anatole Broyard, a very complicated man. He was a critic for the New York Times Book Review. And he, in his late life, he developed prostate cancer. And he wrote a book that we teach to our medical students called Intoxicated by My Illness, describing his prostate cancer. And this is what he had to say about his doctor. He said, "My doctor knows all there is to know about the prostate, but I cannot sit down and have a talk with him about it, which I find a very great deprivation. What a curious organ. What can God have been thinking when he designed it this way? I would like to have a meditation, a rumination, a lucubration, a bombination about the prostate, but I can't do it. I'm forced to stop people on the street and talk to them about it." And then he goes on to say something very important. "I just wish my doctor would brood on my situation for perhaps 5 minutes, that he would give me his whole mind just once, be bonded with me for a brief space, survey my soul as well as my flesh, to get at my illness, for each man is ill in his own way." I want to restate that. Each man or woman is ill in his or her own way. And one of the important functions that a doctor serves from the patient's point of view is the sense that they are bonding with you and occupying their suffering with you by giving you their whole attention. I want to move on to physician wellness. When you get everything on medical records on the computer, when you become very, very data heavy, unfortunately, it comes with the problem of doctor burnout. At least in America, the electronic medical record, we find we're spending so much time on it. For every 1 hour I spend with patients, I must spend another 2 hours on the computer and another 1.5 hours at home looking at my inbox and dealing with all the messages and alerts that are coming because of my time on the wards. And this is causing widespread burnout. By some estimate, 50% of physicians are burnout. So you know that this is a systemic problem. This is not a unique individual problem. And it's being caused by a very clumsy, inefficient medical record keeping system. Even though it's computerized, it requires a lot of keystrokes. The third consequence of moving from the bedside to heavily data-driven model is, of course, medical error. And by the way, I want to tell you, I'm not suggesting we go backwards. I am suggesting that we find a way to keep the best of both. You need both, and that's what these consequences are about. What do I mean by medical error? You know, every time we have our attention distracted by a device, then we don't pay attention to what's in front of us. This is something that I suffer from. I'm sure you do too, where you can't be anywhere without checking your phone. But it has consequences. When you're distracted while doing an important task, and this is true in medicine or driving, then you can have consequences. I had somebody do this cartoon for me because it shows this individual who has been run through by the Titanic, let's say, and the physician is saying, well, let's get a CAT scan and consult the gastroenterologist and figure out why you're having these pains. I think we are too dependent on testing, and sometimes we're not willing to see what is obvious with the patient. Some time ago, we did a study where we asked other physicians to tell us about stories where some oversight in the physical exam had led to a consequence, such as a misdiagnosis, a delayed diagnosis, unnecessary surgery, unnecessary radiation exposure, or death. And we collected about 100-something stories before we published. And as you can imagine, the number one reason for these kinds of errors is that most people, despite recording the exam in the computer, they hadn't actually done it. They had not actually done the exam. And I think when you ignore the body and you rely only on data, you get into some real big trouble. What kind of examples? Well, a patient coming in with chest pain goes straight to the cath lab to get the cardiac catheterization, and they're doing the catheterization, they're injecting contrast, and then somebody notices that they have a rash on their chest wall that is confined to a dermatome, and that looks like dewdrops on rose petals, and this is shingles or herpes zoster. So many examples just like that of obvious diagnoses that were missed because of a reliance on data. And lastly, I think the danger of abandoning the patient exam is that you lose a very important ritual. Coming to Stanford, I had the chance to interact with my anthropology colleagues, and I used to tell them how when I examined patients, especially difficult patients with chronic conditions, people who have gone to many different doctors, I will spend a lot of time on the exam. And sometimes I find that the patient becomes very silent during the exam. And oftentimes people will say to me, I have never been examined like this before, even though all that I did is exactly what we teach first and second year medical students to do. It's just that nobody's doing it. And I talked to my colleagues in anthropology and I told them how, some of these very difficult patients, when I do the exam, I feel that I get a connection with them that is different than before we started. Something has happened. And I started to tell them the story and they immediately stopped me and they said, Abraham, you are describing a ritual. And they taught me that rituals that we all engage in are all about transformation. A wedding is a ritual of transformation, a funeral, inauguration of a new president, which we're trying to do in this country despite some resistance. All of these are signaling the crossing of a threshold, a transformation. Well, if you think about it, the ritual of a stranger coming to see one of you or coming to see me, telling us things that they would never tell their wife or their rabbi or their preacher, in my case, in infectious disease, telling me things they would never tell their spouse. And then they are in a room whose furniture does not look like the furniture in your room or mine. And one person is wearing a white shamanistic outfit with instruments in the pocket, and the other person is wearing a paper gown or a disposable gown. It has all the trappings of ritual. And then one individual in this pair, in this dyad, one of them disrobes and allows touch, which in any other context in society is assault. It's a violation, it's a crime. But because of the sanctity of the patient-physician relationship, because of our fiduciary responsibility for the patient, we are allowed to do this very skilled exam. And it has a function well beyond diagnosis. I think it brings about a transformation. What is the transformation? Well, it's preserving the identity of the patient. You are saying to the patient, this abnormality is on your body. It's not on a computer screen somewhere. It's not on a lab report. It is on your body. You're centering your attention on the body, and patients, being human beings, they need that. They need to feel that their body is the locus of this problem that they came to, not an image or not a biopsy. So I think I will wind down there by saying, from the time we first began in medicine, we've always known that this skill of examining patients is very hard to teach. You have to do it at the bedside one-on-one. It's very hard to do by Zoom or virtually. It is like an apprenticeship. This is a picture of an Indonesian sword craftsman teaching this little boy how to be able to do this. If he does not pass on this knowledge, the knowledge dies. I think it's the same with you. That's why I'm very, very excited to be talking to first-year medical students. You are going to learn a lot of sexy science and genome, metabolome, proteome, but don't get too far away from the body. Find the doctors who are really good at this skill. Have them hold your hand and show you how to do things well so that you can read the body. The body is a book. The body is a text. You need to learn to be able to read it very, very well. And you need to be able to teach it, to pass it on to the next generation. Many years ago, William Osler, I hope you know that name. He was like the grandfather of American medicine. he said that patients will form an estimate of you by the way in which you conduct yourself at the bedside. Skill, whether in the simple act of feeling the pulse, will establish more confidence in you than any diploma. So I want to leave all of you with this thought. I know that you're going to have a wonderful session today. I know that your discussions are going to be very much about technology, but I would ask you to not to get too far away from remembering the patient and remembering that that patient is a very vulnerable, complex human being who needs your attention, needs your attentiveness, who needs your touch. Many years ago, Francis Peabody said, "The secret of the care of the patient is in caring for the patient." I hope all of you medical students will carry that phrase with you, even as you remember all your Krebs cycle and all the other things that you'll also carry. Carry this one phrase with you. If you want to care for the patient, it begins by caring for the patient. Thank you so much, Leandro, for allowing me to have this chance to speak, and I'm very happy to take questions. I'll stop sharing right now.
Thank you very much, Professor Verghese. That was a very, very, very inspiring talk. And I think the end of it was exactly our goal with inviting you here, because some people, we got questions of people like, it's an event about technology. Why are you talking about the doctor-patient relationship? And the thing is, in my view, is that sometimes we forget, we focus so much on studying medicine and studying technology because of medicine and because of technology itself, that sometimes we forget that the patient is the central thing here and the most important thing that we're studying, you know. And no technology will be good if it doesn't help the patient. And we have to remember ourselves all the time about this. Thank you very much.
Well said. Thank you.
Thank you very much for the lecture, Professor Verghese. It was amazing. Now we would like to present some of our spectators' questions. The first one we received was, how can we conciliate the use of technology with a good doctor-patient relationship?
Yeah, I think that one of the things that I'm counting on your generation to do, because our generation has failed, is that you have to make sure that the technology that is being invented, that you try and anticipate the consequences of the technology. In other words, the electronic medical record seems like a great idea, and it is a great idea. I don't want to go back to paper, but it was poorly thought out. And the government in America made a mandate that you have to all switch to electronic medical record. Well, it turned out there were only 2 large electronic medical record systems that were capable of, handling big hospitals with all their clinics. And the focus of the technology was entirely on billing, on being able to capture the last dollar from the insurance company, from the government. And, just to show you how inefficient we can be in medicine, the average nurse in 1 week on the ward hears something like 20 to 30 alarms going off. Bing, 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 all the time. And what do we do when we hear an alarm? We ignore it. We don't pay any attention to it because there are too many of them. They're going off all the time. Contrast that with the Boeing 747 cockpit. That computer electronics is designed solely for the ease of the pilot flying the plane and the safety of the passengers. There are very few alarms that go off. When they go off, they are color-coded and you respond to them because they're rare. So I think we have, my brother is a professor at MIT and he walked into an ICU one time with me and he was looking at all these machines in the ICU, monitor for this, monitor for that, pulse, blood pressure, oxygen, you name it. And so then he asked me, where is the central computer where all this data is gathered? And I had to break his heart and tell him there is no such thing. Most of the time we ignore this. We just come in and we look at this number and that number. So even the technology we have, we're not beginning to gather the data that it offers. So I would say that, we do need technology. I'm not a Luddite. I'm not trying to go back in time, but you really have to try to anticipate the consequences. You're discussing AI, and I've written several papers on artificial intelligence, and it has a bad tendency to quietly exacerbate our prejudices, whether you're using it for deciding who to give loans to, who to give bail to, deciding, how to adjudicate healthcare. It tends to amplify our biases. So we have to be very careful. We are humans, and the technology will simply do exactly what we tell it to do. And sometimes that's not a good thing.
Thank you very much for the answer. On that matter, we have another question. What is the role of future medical students and other future healthcare professionals, as well as our mentors, in breaking down the barrier of misconceptions surrounding the technological advances in the healthcare field?
Yeah, I actually think that the great challenge to our generation was, learning to use this technology in an efficient way. And I think what I really like about your generation, first of all, they can't believe how inefficient some of our technologies are. And secondly, many of them have, basically taken side routes from medicine to try and improve the technology. So we have several Stanford medical students who, when they came on the wards and one of them saw how much time we were spending on the medical record, he thought that this was so inefficient. He actually left medical school. I have not seen him back in medical school. I saw him at the Aspen conference, but he started a company that was basically using the Google Glass so that when the physician is examining the patient, a scribe far away can capture all the notes, and so that when the physician comes out, they're done. They have a few exchanges with the scribe. That is still kind of a back-assed way of trying to fix a complicated problem. But I think that we're looking to you, all of you, to look for opportunities to innovate, to look for ways that we can do things cheaper, better, safer, with more patient satisfaction. And I think there are endless opportunities for that. Just keep your eyes open. Stay close to Leandro. He'll show you what to do.
Professor, I have a question myself. So I was just rewatching today your TED Talk. It was recorded on July 2011, so it's almost 10 years now. And you say in your talk that the revolution of the next 10 years would be the hands. So we're 10 years from now. Did it happen? What do you think changed in these 10 years? Are we better or are we worse?
Well, I wish, I'm an optimist. So when I said that, I think I was being as optimistic as I could be. I think in those 10 years, we've done a lot at Stanford to try and celebrate the bedside, to try and teach the bedside. I'd like to encourage all the students here, please check out something called the Stanford 25. This is a place where we try and teach medical students. I mean, it's done live at the bedside in Morning Report, but our students said you have to have a website. So we have a website with some interesting videos. But, I think what we've tried to do is make students aware that technique matters. Leandro, in your business, if your technique is not good, you can't repair the labium or, you can't put in a new hip joint. Well, I think the technique of examining a patient is also very technique dependent. I can give you a reflex hammer, but if you don't know how to hold it, if you don't know how to position the patient's limbs, if you don't know how to strike the hammer just so, if you hold it too tight, you will not get the reflex. And an absent reflex is a very significant phenotypic finding. So I think we're very good at getting genotypic findings. We are very bad at getting phenotypic findings. If a patient walks into my office and I can see the outline of a cigarette packet in their pocket and they are male, I already know much more about their cardiovascular risk than any genotype you want to give me. And I think it's that kind of, elemental observation that we still need. I'd like to think we're getting better. I must also say that I think the masters of this art are really in your countries. I think in Latin America, in much of the Commonwealth, people still celebrate and are really good in these values. I have had a chance to look at some of your physical diagnosis textbooks, and they're just amazing. I mean, I wish I could read fluently in Portuguese, but I can already tell that, this is really celebrated where you are, and that's wonderful.
Amazing answer, Professor Verghese. Now, our next question is, What were the lessons learned from the pandemic in terms of doctor-patient relationship?
Yeah, it's very interesting because the pandemic really has challenged our ability to see each other's faces. We're all masked up, the patient's all masked up. And one of the interesting things that one of my colleagues here did is she actually took pictures of the doctor's faces and printed it in a big size and put it on the gowns so that, the patient is seeing a person, not just these hooded figures. And frankly, I found that we're all getting used to the mask. I wear hearing aids. I'm a little challenged in my hearing. And it's been really hard because when people's lips are covered, I didn't realize how much I was lip reading. That is also true of our patients. Many of our patients are, elderly, they're hard of hearing. So it is a real challenge, but I feel like it's made us all more attentive to the patient, more close. Obviously, if they have COVID, it's a bigger barrier. But, I don't think it's stopped us from doing what we need to do. There's a much more danger that we'll overlook things because of all the barriers, I don't know if you know of a book by my friend Atul Gawande. He's a well-known surgeon and writer. He writes for the New Yorker, but he had a book called Checklist. And I like to tease him that I want to make my own checklist for the physical diagnosis. And the number one will be patients have a backside and a front side. And it's really important to turn them over and look at the backside because lots of juicy things happen there that can be responsible for the fever, the falling blood pressure. And it's amazing how often people don't look. And there's no test in the world that's going to tell you that. You just have to turn them and look.
Thank you very much for the answer. So our last question is, if you could give the students watching right now a final advice on how to learn to create and maintain a meaningful connection with patients, what would that be?
Well, I think that you students come to medicine with a wonderful capacity to imagine the suffering of patients because you have seen it in your family, perhaps. You really have a tremendous capacity to imagine the suffering of patients. And a very strange thing happens when you go from your preclinical to your clinical years, or as I call it, from your pre-cynical to your cynical years, and you begin to lose that capacity to imagine the suffering. And it's our fault because we make you focus so much on disease that people become the diabetic in bed 3 and the heart attack in bed 4, and it's our fault. So I would say to you, when you make this journey into medicine, and it is a journey, you will not be the same person you are now, Renata. You'll be a very different person when you come out. But keep your own pulse. Be very conscious of how you're changing. Try and retain the capacity to really imagine the suffering of the patient. I think the very simplest advice I'll give you is imagine that every patient you see is your mother, your father, your brother. How would you treat them? That is what you need to do. That's all.
Well, I thank you, Professor Verghese, for your exceptional participation. It's a great honor for us to have you here on this special day. And I give the word to Dr. Leandro again.
I just want to thank you again. I'm sure this is a day that all the students from MedTech will remember forever. I'm sure this is a day that I'll remember forever.
Thank you.
Thank you very much. And I hope when this pandemic ends, we'll be able to meet in person here in Brazil. It would be an honor to have you here and have some caipirinha with us. Thank you very much.
I'd love that. Thank you very much.
And we move forward to our meeting. Thank you.
Bye-bye. Thank you.